Good afternoon. I am Dr. Tavish Gupta and I will be speaking about the great Mimicker. Presenting a 46-year-old male with left eye painless progressive diminution of vision for the past 4 to 5 days associated with a central defect in the visual field. There was no similar episodes in the past and the patient had a history of pulmonary TB in the past. On examination, the right eye anterior segment was within normal limit and the left eye best corrected visual acuity was 3/60 with a few AC cells and retrolental cells present. On fundus examination, in the right eye, we can see multiple pinpoint circular creamy white lesions, and in the left eye, we can see disc hyperemia and the nasal margins were blurred. We can also see a geographical area of ground glass translucence of the retina with some punctate creamy colored retinal lesions associated with it. Now on zooming in, we could also find perivascular exudation also present, and these findings were confirmed on the fundus autofluorescence, in which the geographical area is well delineated with hyperfluorescence. On macular OCT, we can see multiple hyperreflective dots more in the outer layers with disruption of the outer layers, broadening of the RP excrescences, and hyperreflected dots in the choriocapillaris, which was confirmed in the peripheral OCT also. Now we have a patient with papillitis, retinitis, and vasculitis. But as in this patient, we have a characteristic retinitis, and mostly the causes of retinitis are infectious. So we should first rule out infective causes before going to other causes. Now the infective causes can be neuroretinitis, viral retinitis, toxo, TB, or syphilis. And if infective etiology is not elicited, then we move on to the inflammatory causes. For neuroretinitis, although our patient had retinal and disc involvement, but our patient also had peripheral involvement and an absence of any macular hard exudates. So we ruled it out. Now for viral retinitis, our patient did not have any confluent 360-degree lesions near the posterior port, nor did he have any hemorrhages. And for ARN also, the patient did not have any characteristic opaque white lesions. So we ruled viral retinitis out. The patient also did not have any focal retinitis with extensive vitritis above it, nor did he have any granuloma. So we ruled out toxo and TB. But the patient had yellowish placoid lesions with vasculitis and a ground glass retinitis. So then we went back to the history and asked leading questions, and the patient revealed that he had a history of genital ulcer a few months ago with papilloerythematous lesions, and he had multiple sexual partners in the past, and his wife also had multiple skin lesions. Now ocular syphilis can present in a wide variety of manifestations, the most common of which are posterior and panuveitis, especially the acute syphilitic posterior placoid chorioretinopathy, in which there is ground glass retinochoroidal lesions due to the indirect immune-mediated hypersensitivity to the Treponema pallidum. And the fundus autofluorescence and OCT features of our patient are similar to those described in literature for ocular syphilis. Now the patient and his wife were investigated according to the reverse sequence syphilis screening algorithm and were found to be VDRL and TPHA positive. And so, according to the SUN working group classification, we came to a diagnosis of ocular syphilis. And all patients of ocular syphilis are treated on the lines of neurosyphilis. So we treated our patient with injection ceftriaxone, and our patient improved in the lesions in both the right eye and the left eye with an improvement in the visual acuity to 6/18. And this resolution was confirmed on fundus autofluorescence also. So the uniqueness is the clinical features which are found in our case, the ground glass rendered translucence and the creamy white lesions and the characteristic OCT and FAF patterns. And the clinical implication is that ocular syphilis should be considered in the differentials for atypical lesions, retinal lesions, due to the ability to mimic various inflammatory and infectious conditions. And the ophthalmologist has a major role in the early diagnosis. And the treatment is supposed to be a multidisciplinary management on the lines of neurosyphilis. Thank you.
Nice presentation.
Your take-home message what is your take-home message from this case?
So the take-home message is that in any case, syphilis can present with any inflammatory condition. So in any case of posterior uveitis, we should have a low threshold for testing for VDRL and for keeping syphilis as a differential diagnosis.
All cases of
posterior
should be tested for syphilis. That is a take-home.
Yes.
Thank you.